Hello everybody and welcome to our third Ask the Expert Q&A, where you get to ask questions and hear answers from experts about important PSC issues. I'm Martine Walmsley. I'm the Chair of Trustees and volunteer for PSC Support, and I'm a PSC patient. And I'm here with Maxine Tapp, PSC Support Programme Development Officer. And we're delighted to be joined here today by Dr. Palak Trivedi. And Dr. Trivedi is a clinician scientist and consultant hepatologist in Birmingham, which is a liver transplant centre and has the largest PSC clinic in the UK. Dr. Trivedi is a chief investigator for UK-PSC, and he's the chair of the BASL Immune-Mediated Liver Disease Special Interest Group. And that's a national group that's interested in researching autoimmune liver disease. And Dr. Trivedi is a pioneer in patient-centered research, so he listens to what patients are saying, and he's worked with many PSC patients from all over the UK to develop research ideas and study design. And it works incredibly well, and this is actually how all research should be done. For those watching live, you can add your comments and questions below in this video. We've got a lot of questions to get through, and we'll try to ask as many as we can in the next 30 minutes. So welcome, Dr. Trivedi.
Thank you for having me.
The first question is a general question about research, and it also relates to COVID, and it's about the Merlin trial. So when do you think that will be back up and running? Because there are some people that were eligible to take part, and they're really keen to know what's going to happen next.
Gosh, that's a tough one to start with. I wish I could be more concrete in the answer. So thank you for having me all. So I suppose the question is not just specific to the Merlin trial, but also the broader clinical trial portfolio in PSC. So at the moment, in Birmingham at least, the lion's share of non-COVID research is currently on hold for two main reasons. One is obviously the risk it poses to everybody involved, the patients, the staff, for having a non-routine clinical visit to the hospital. But more so than that, we also need the staff to deliver it. And all my research staff have been redeployed to support COVID-related programs, the vaccine trial, to name one. Now, we are having meetings regularly in a virtual setting as to when and how we prioritize liver research. So certainly PSC is my priority area. That will take place hopefully at some point this week, and we are each nominating our studies to reopen. I'm hopeful that with Merlin and with the other PSC trials, we should be able to reopen in July or August time, but I can't confirm that just yet. The anticipation is that yes, then all research trials will reopen in some capacity, but albeit with reduced study visits or studies where you're supposed to have a physical examination that will be limited to a chat and a blood test. But at the moment, it's still very much to be decided. And again, we all hope there isn't going to be a second wave, but that may also put a hamper on what activity we can and when we'll open.
Thank you. So it's very much a case of watch this space and keeping patient safety first.
Yes. And I'm hopeful it will be in the next month or two.
Brilliant. Thank you. Well, let us know when they start and we'll definitely tell people. So the next couple of questions actually are a little bit around the microbiome. So the first one is about vancomycin. So somebody has been taking vancomycin and they're wondering, and this is very much an experimental drug, isn't it? It's not properly licensed for PSC. And how long is it safe for them to take for?
Yeah, good. So that's another very good question. So just a bit of background for those who don't know much about the data around vancomycin, what it is, what it does, and how it may or may not benefit patients with PSC or people with PSC. So vancomycin is an antibiotic, and as with all antibiotics, we have caution about how long they're used for and them being used in the right way and for the right amount of time. The unique thing about vancomycin is that it is not absorbed systemically. So if you take it by mouth, it stays within your gut. It is not absorbed or very minimally absorbed. So it has a very low side effect profile in terms of symptoms and also long-term damage to other organs. The data around vancomycin stems from the fact that we know that PSC has an association with inflammatory bowel disease, and there is a wealth of data now showing that the gut microbiome, the bacteria, the fungi, the viruses that everybody has in their gut are different in people who have liver problems versus people who do not have liver problems. And equally, people who have PSC, their gut looks different to people compared to those who have inflammatory bowel disease alone. Now, vancomycin as an antibiotic that stays within the gut, for that reason, has got attention. And there's data predominantly from North America and the Middle East, which shows in people with PSC, taking vancomycin, the alkaline phosphatase, which is a blood test marker, reduces, and in some patients completely normalizes following therapy. Now, these are very short duration studies stemming anywhere between, say, 2 weeks up to 3 months. And then there is now emerging data for longer term use vancomycin in people going sort of beyond 3 months data. And I believe there are some studies in the US looking up to 48 weeks and up to a year. Now, whilst it has minimal side effects and it's tolerated very well for the vast majority, with any long-term antibiotics, our concern is around antibiotic stewardship. What I mean by that is you can promote the emergence of resistant bacteria. So bacteria within the gut that may be harmful in other ways because it becomes tolerant to a particular antibiotic. And for that reason, studies are ongoing in the United States, as well as elsewhere in the world, showing that, or testing that vancomycin taken for beyond 3 months is actually safe. To answer the question, I would not be confident, or based on the data that we have, for people taking vancomycin, say for more than 2 to 4 weeks, because the number of patients in the whole world that have been published on where vancomycin has been given for longer than that is very few. 3 months is the most I've ever given vancomycin for to an individual, and certainly beyond that there is no data to suggest that either that it is safe or continues to have efficacy, continues to have benefit. So 2 to 4 weeks is what I would usually give. Beyond 3 months there is very scant data, and I wouldn't be comfortable. Good,
thank you. So vancomycin is doing something, isn't it? It's altering the microbiome, possibly. Yeah. So can you talk a little bit about research that's about fecal microbiota transplant and the microbiome, and if there are any research trials in the plan?
Absolutely, absolutely. So the microbiome changes that we see in PSC, there are some schools of thought that it's too much bad bacteria. So there are certain bacterial species which are more prevalent in the gut of patients with PSC compared to those without PSC. And that's where the vancomycin story comes in. If you remove those harmful bacteria, then it improves liver blood tests, and that's the proposed rationale. The rationale behind fecal microbiota transplantation is from the other school of thought. So it's not necessarily there's too much bad, it's the fact that there's not enough good bacteria. So there are many more bacteria in the human gut than there are any other cell type in the human body. And if we were to promote favorable growth or by transplanting good gut bacteria rather than depleting it, then theoretically that's more sustainable. That's an approach which is much more natural. We know that if you move from one country to another, or even if you start changing your lifestyle and reduce your body weight, your gut microbiota changes in line with that. And studies from animals have shown that you can favorably alter the course of their liver injury by transplanting gut bacteria. There is one published trial in PSC and many published trials in inflammatory bowel disease alone, looking at what fecal microbiota transplantation does. Now, before I get into those results, and certainly where we are now in the UK, it's just worth knowing that no two people's gut microbiota is exactly the same. Even twins who live in different locations will have different gut microbiota. So studying what classifies, I mean, and to be colloquial, what is a golden stool, what is a favourable stool to alter gut microbiota, that research is still ongoing. In PSC, there was one study published again from the United States of where they used fecal transplantation in 10 people. The main aim was to see whether it's safe, and it was safe. There was no significant adverse events documented from that study. And in 3 out of those 10 people, their alkaline phosphatase values reduced or improved rather. And in an additional sort of 6 patients, other liver enzymes also improved. Now that was a very short-term study just showing whether it's safe and well tolerated. In the inflammatory bowel disease field, the data is much more robust, and they've also been able, and there is a trial ongoing in Birmingham led by my colleagues who deal exclusively with IBD, and collectively that data has shown that about 40% of people who have fecal transplantation have some degree of benefit. Now that benefit can be the ability to come off some of their inflammatory bowel disease medication. In others, it translates to a benefit of unstable inflammatory bowel disease that comes under control with whatever medication they're on, so without need of escalating therapy. And in others, it's a clinical benefit wherein they've reduced the frequency of stool passage every single day. Where we are now in terms of exploring this further, Birmingham certainly is a centre that's putting in grant applications as we speak to do fecal transplantation, compare that to routine standard of care in people with PSC, to see whether there is actually more meaningful benefit. So not just whether it improves liver blood tests, but also whether it improves quality of life for patients from a bowel and liver perspective. And after a short course of fecal transplantation, so it's not, we don't ever envisage doing a fecal transplant every day in somebody, that will just be cruel. But if we were able to, for example, provide fecal transplantation by means of your surveillance colonoscopy, and then provide it a few top-ups via enema, then with a long term that change in your gut microbiota is sustained, and whether that translates to long-term benefit in quality of life, liver blood tests, compared to standard of care, compared to a daily vancomycin tablet, and so on. So we are certainly putting in applications as we speak to that effect.
It's certainly, when you talk about those short-term benefits, albeit IBD and so forth, it really sounds attractive, and I think I look forward to that study. That's very exciting. And now a question still on the microbiome, and not exactly research, but is there anything that we can eat that may favourably alter our microbiome?
That's a very difficult question. Again, these are tough ones. In terms of so the short answer is no. There is no data saying that a particular change in your diet, if you have PSC, is going to favourably alter your microbiome. The 3 things that that are pointing in a positive direction. The first thing is coffee. So it's not caffeine, it's coffee. The one thing is that it's not necessarily a microbiome effect alone, but there is a wealth of data now, observational data, to suggest that people who drink 3 to 4 cups of coffee per day live longer, have better cardiovascular risk profiles, and have better liver disease risk profiles. And certainly there are some studies in PSC specifically showing that coffee drinkers have a better outcome long-term compared to non-coffee drinkers. And it doesn't matter if it's caffeinated or not, it's not a caffeine effect. And I must stress this is observational data, not trial data. So it's just an observation. And there may be other lifestyle things that coffee drinkers have that non-coffee drinkers may not. So, but it's certainly something that we observe. The second thing is just, very simply eating a good, well-balanced sort of diet. So a diet that's doesn't have too many simple carbohydrates, a diet that doesn't have too much saturated fat, a diet that's got a very high protein content, are all good things for liver health and overall health. The third thing of which there is emerging data from a dietary perspective are the effects of vitamin D and curcumin or turmeric. Now these are things that have been tested in mouse models which are obviously very different to humans, but it's the closest thing we have to study the effects. And I'm not saying that individuals should load up on turmeric or load up on vitamin D, but certainly sort of supplementation to keep your vitamin D levels at a normal level rather than a low level is particularly important when you live in the UK, because vitamin D comes from sunlight and we don't get a wealth of that here in the UK. So certainly those are some simple dietary changes or lifestyle changes which sort of are pointing in a favourable direction currently.
And if you decide that you want to top up on vitamin D, is that something that you just need to check with your consultant first, or is it just classed as like a multivitamin and you could just get some and try it?
No, so multivitamins by accredited brands are fine, but what I would strongly advise is in the winter people's vitamin D levels fall because we have less daylight. So it is not uncommon for your consultant to advise you to take multivitamins or vitamin D supplements specifically in the winter months. The second thing to mention is when you have your routine blood test with your doctor as part of your PSC health check, I always check vitamin D in patients at least sort of once to twice a year because of that seasonal variation. And I would advise patients to ask for the same. If vitamin D levels are low and you are taking a supplement, it may be that you need a higher dose to get your tank up to a normal level and then continue with your daily supplement to reduce the chances of it falling low again. There's a common misconception that just because people take multivitamins, they do not need to have a higher level of vitamin D. And vitamin D has all sorts of effects on your immune cells. It has a contribution with fatigue and pain. And certainly people who have symptoms of fatigue and pain, if their vitamin D levels are low, one of the first things I do is replenish those stores, because that's a very treatable option for symptoms that trouble people with PSC. So and just because somebody's taking supplements, it doesn't mean that their levels may not have fallen.
Lovely, thank you. I'm going to ask you one more question on research, and then we'll take a couple from, I can see some more research questions coming in on Facebook as well. So this one's about exercise and fatigue. So you mentioned at one of the information days about the EXCITE study. Can you give us a very quick update on that? Yeah,
sure.
Please.
So the EXCITE study, it's an abbreviated name for a study which is about exercise intervention in people with cholestatic liver disease. Now, originally, it was funded purely for people who have the related condition primary biliary cholangitis, or PBC, and we're hoping that we will be able to obtain funding to do the same in PSC. What it is, the background to it is, one of the reasons why people become fatigued when they have PSC and PBC is because when you move your muscles, when you move around, and your muscles develop a degree of acid, those levels of acid do not normalize at the same rate as people who don't have PSC and PBC. And data from the Newcastle group about 10 years ago now showed that certain types of exercises are able to restore that balance to some degree and take away the fatigue-related symptoms. And on this basis, we are also there is also trials ongoing in people who are on the liver transplant list, showing how some exercise interventions can take you from being not transplantable because you're too sick to getting you to the stage where you can have a liver transplant. So we then applied to get to do a research study in cholestatic liver disease, but because the data is strongest in PBC, we were given money for that, and then we hope to translate that to PSC. We wanted to do the study in 40 individuals, but because of the COVID pandemic, as with many other things, we got to approximately 30 patients, and we had to put the study on hold. We are submitting the study results for discussion at a research meeting later on this year. I can't discuss the findings in full, except to say that that all the 30 patients did experience some improvement in their symptoms of fatigue. And I can't give you the exact number, but a good number did report that the fatigue went down to a rate that is akin to a normal somebody without their disease. So it's positive results, but I can't quantify it at the moment.
So the EXCITE trial is living up to its name, would you say?
Yes, at the moment. Yeah.
Everyone, what I did there then.
Yeah.
Very good, very good.
The two things I'll say about that study. So it was completely something that was led through, like it's investigator initiated. It's not funded through. It's not something that we're dependent on an industry sponsor. We are sort of sponsoring that study in house. It is set up to improve the lives of people sort of who have cholestatic disease. The next stage to prove would be, compared to routine standard of care, how does this exercise intervention compare? So the next stage will be comparing this data to people who don't have any intervention, and that's something that we will apply for. And in parallel, most importantly, is showing whether the results of PBC translate to those individuals with PSC. So we will be applying for funding to do exactly the same thing, but specifically to individuals with PSC.
Brilliant. No, that's really good to know. Okay, so there's loads of comments on Facebook, and Maxine, do you see any research questions you want to ask now?
I was wondering if we could actually change the subject slightly, because we've had a lot of questions about the relationship between IBD and PSC.
Yeah.
And the first question is from Jessica, and she says, my partner has ulcerative colitis and then he developed PSC. He's been told that his colitis is in remission. So does this mean that his PSC will stay under control as well?
Okay. So thank you, Jessica, for that question. So as with most people, the colitis is identified first, and we know through data from the UK and elsewhere that that's usually the pattern that it follows. In short, keeping the IBD, the colitis in remission is incredibly important, but it does not necessarily mean that the PSC will follow the same suit. What it means is that we see flares of PSC in people who have colitis that is not well controlled. And there are various different meanings of remission. Is it remission based on symptoms, or is it remission based on the colonoscopy, or is it remission based on the biopsies taken from that colonoscopy? And certainly the deeper that remission is, the better the long-term outcome is. So if the remission is indeed at the time of colonoscopy, as well as the biopsy findings, that's best. But what I don't know is what stage your husband's PSC is at the point it was diagnosed. What we are seeing is that people who have a colectomy very early on in their clinical course, who have PSC diagnosed very early, they are less likely to progress their PSC. So it's a bit of a waffly sentence, but what I mean is that a very early colectomy in somebody who's got very early PSC, it's unlikely that will progress in any way. And that's just data from Scandinavia and elsewhere. Sadly, most people are diagnosed when there is a degree of inflammation in their liver, and they've probably had PSC for longer than they think, and that's why it still progresses.
And then, so we've had another question, which is, have you found that post-transplant IBD would get worse, perhaps because of the immunosuppressants?
Okay, so PSC after transplantation does behave differently to PSC before. So if I could also refer back to Jessica's question, what we see is that people who have had a transplant, but who have had a colectomy and they've got their stoma going into that transplant. So they've had PSC and IBD, they've had a colectomy and they've kept their stoma. They haven't had a pouch or anything like that. And then they have a transplant. It's very unlikely that their PSC will come back in their transplanted liver. People who have had a colectomy and who have a pouch, sadly, the PSC does tend to come back. And people who've got PSC and have not had a colectomy at all, because they've never needed to have one, PSC can come back in their transplanted liver. Now, the current question, which is the reverse in many ways, is what does the IBD do? In people who've got their colon intact or who've got a pouch intact at the time of transplant, about 30 to 40% of people will have worsening colitis. after their transplant is done. And about 30 to 40% of people, their colitis actually gets better, and the remainder, it just does what it was doing beforehand. It's unchanged. So it really is sort of a rule of thirds. A third get better, a third get worse, and a third, it's no change. Now, trying to find out why that is something that we are currently doing. The group of people who have had a bit of inflammation going into the transplant, but not severe enough to warrant any particular therapy, that's the group that's more likely to have problems after they're transplanted, which is what we would think. But yeah, about a third of people, it actually gets better, and about 30 to 40%, it actually gets worse.
We've had a few comments, actually, people just commenting with those experiences, some saying theirs has got worse and some saying actually it's loads better. So yeah, that proves the point, I guess.
Yeah, and I mean, the people who, if it gets worse within the first year or two after they're transplanted, sadly, that's the group that are most likely to need an urgent operation, an urgent colectomy. And I mean, intuitively, that makes sense, because when you are transplanted, for those of you who've had a transplant will know, the first couple of years are the time frame when you're on the most immunosuppression to prevent rejection. And that same medication is more likely to keep your colitis in check. But if you flare up after the first couple of years when you're on less immunosuppression, there's a lot more medication that we can try.
That makes sense, yeah. Thank you.
Thank you. Now, I'm conscious now it's our time is up, I'm afraid, and we've still got lots and lots of questions to get through.
Yeah.
And so we'd love you to come back if you wouldn't mind, Dr. Trivedi, and maybe we could focus on PSC and transplant as questions, because there were quite a lot of those ones. That would be really good. And also, we've still got lots of questions to ask, actually, just about general routine care and also prognosis, loads of questions actually. So it'd be really great if you could come back and answer some more another day, if you don't mind. Excellent. Well, thank you very, very much. And thank you for answering all these questions so comprehensively as well. It's really good to get the good inside track on some of these, especially the research ones. So I'm going to leave the last word to you, Dr. Trivedi. What is your takeaway message for people living with PSC at this moment?
So, I mean, at this moment, it's a bit of a dark time for everybody, but things are getting better. Things will get better. Trust in your doctor. We're always here. And at the moment, the hospital most hospitals are a safe place if you have healthcare need. Don't be afraid to ask for help.